Hello, everybody. Welcome to the Master Spoke out of the studio of the Egyptian Society of Nephrology 2022. My name is Hisham Said. I am professor of nephrology in Shams University, Cairo, Egypt. I am the chair of hemodialysis chapter of the Egyptian Society of Nephrology, as well as the Afghan Society of Nephrology. It's my pleasure and honor to be here with one of the big figures in hemodialysis and in nephrology. Professor Bernard Canuad is one of the pioneers who initiate and maintain and drive all the updates in nephrology and dialysis. I will keep him as a friend always because we learned a lot from his side and we are still in agony that we have to make some cooperation with his side and his long way of experiences. I am welcoming also Professor Bernard Canuad in our meeting as a very good contribution. Please, Prof.
Thank you very much for your kind introduction. I am Bernard Canuad. I'm Emeritus Professor of Nephrology in Montpellier University, but also Chief Senior Scientist at the Fresenius Medical Care. And I'm really happy to share some experience about the nephrology and particularly in dialysis, and I'm really happy to have this collaboration because the idea is not to teach, but the point is to make a collaboration, a sort of win-win situation, because we know and we learn all together and we just face some difficulty in Egypt, and I'm happy to help this, I would say, Egyptian Society of Nephrology and Transplantation to face this difficulty and to find some new way to improve the care and the outcome of the patient, because at the end we want to improve the outcome of the dialysis or kidney patient.
Sure, that's my concept as well as a chair of the Afghan hemodialysis chapter. So we have to support our friends, neighbors in the initiation of dialysis as well to run and maintain. She will be on the basics of patient survival as well as the quality of life. Professor, yesterday we had learned too much from your talk about the hemodialysis filtration. Can you just give a highlight? What's the update in hemodialysis filtration?
Yeah, that's a good point. Imodara filtration, as was presented yesterday, is what we call a convective-based therapy. So it does not mean it's completely different from the regular hemodialysis, but what the Imodara filtration brings, it's the additional convective action. And we know that convective action or convective clearances, this is the only way to remove some middle and large molecular weight substances. So the idea behind is to combine what we learned in the past by the diffusive action to the convective one to enhance the convective volume and to enhance the diuretic dose given to the patient in order to reduce toxicity of these middle molecular substances. Because we know, and we learned over the last 50 years, that substances in this range of middle, large, and even protein-bound are toxic, and particularly toxic for the vascular system, and particularly for the endothelium. So they contribute to the cardiovascular mortality.
Yes, exactly.
So this is a way to reduce the burden of the cardiovascular in this patient. So it's not a magic treatment, but we have to apply particularly some best practices to make sure that we target the right convective dose to achieve the objective to reduce mortality.
And this is translated actually to good patient quality of life, survival, lower morbidity and mortality.
Correct.
From your clinical experiences, do you feel that and you translated these procedures to actual results to patients' outcome?
So this is exactly the point. With the technique or the modality, we know that we are increasing the clinical performances, but the clinical performances should be translated in patient outcome. It improves the quality of life, reduce the burden of disease, reduce the incidence of hypotension.
Yes.
And at the end, finally, improve the survival expectancy from this patient. So a lot of studies have been performed, and new studies are coming, but clearly we are on the point where the high flux hemodialysis, which was already a new paradigm shift, would be replaced or completed by this convective action and by Imodara filtration.
What do you say to doctors and some of the key makers that still are using low flux dialysis.
Okay, so
What is the message? How we can?
So I understand the complexity, the difficulty in some country, in particular Egypt, because if it's just a point of cost, I will understand that maintaining the low flux hemodialysis makes sense to start a treatment if you are just looking on the cost.
It's the same expenses.
But
in Egypt, both are high flux and low flux.
Okay,
are the same
so
expense.
now if the cost is the same, there is no reason, there is no medical rationale to use low flux membrane. So we need to move to the high flux again to increase the removal of this protein.
Big molecules. So we can say that stop here, stop reusing low flux. Yesterday, I have a journey to the future, like a journey of the future machine, where I highlight where we are going in the roadmap of the future on dialysis. And I highlighted the implantable and the wearable bioartificial kidney. So what do you think? Is it in the near future or still is a dream away?
I think it's not so far away.
Okay.
In the technology,
very optimistic.
No. In the technology is moving so fast that miniaturization, microprocessors, bioengineering aspect are moving so fast that I'm confident that within maybe 5 years we can have some implantable. We have already some portable or wearable device, but implantable is a different story. I'm completely confident that within 5 years we get some clinical trial. It's already in the US in some centers trying to make plan for implantable.
San Francisco,
San Francisco. So this is clear. I would not say it would work perfectly, but still we will have some clinical experience. Again, to complete this element, of course, there is a new way from the dialysis machine where a lot of, I would say, new monitoring are coming on a machine, but this is online system, monitoring the patient. And the next step, and everybody knows, was, I would say, the new xenotransplantation, which would be maybe the next future. So, and the next future is very close because, as you know, the heart transplant, the kidney transplant were performed in US within a few weeks with a tremendous success, which was almost impossible. So the new bioengineering of this new organ, based on some knockout process of this.
You carry a good hope for the patients.
Sure.
That's the near future. May we last that for our life to see that the bioartificial implantable kidney?
I'm sure.
It's just a dream?
No, it's not a dream. I think
so. The dream may come true.
Yeah. The point is, of course, if you think past what's happened with the dialysis and all this transplant, 50 years, and we are already with a treatment which is completely mature. So we have tremendous, and now the process.
I like this optimistic way, and I think this is our message, that the optimistic way of improvement, global improvement of patients on dialysis will come nearly in near future to a good results of the kidney, bioartificial kidney or implantable device that will come to light during the next 5 years. Thank you very much, Professor.
Thank you very much.
Thank you very much.